Awesome. I was just talking, who was I talking to? Somebody I was talking to just recently that they were doing, she's training for nurse practitioner, Amy, I don't remember Amy's last name, but she was working with you last semester for a while.
Yes, yeah, she also works at, the homeless clinic. Yeah, she's great. I think she wants to do Suboxone. I tried to convince her.
She does. She does. It's just a matter of she's thinking about doing a nurse practitioner residency. So it's a matter of if she's going to stay in town or if she's going to go somewhere else and maybe come back. So working on her. Got it. And if you have any patients that you'd be willing to present, that would be lovely. I'm sure people are starting to get sick of the fact that Hennepin's presenting every time.
Yeah, we'll brainstorm on that. I've been thinking about that. Yeah.
Thank you. Appreciate that. Yeah. And I see Natalie Hayes is joining us. Hey, Natalie.
Hi, Natalie.
Hello.
Where are you calling in from today? Richfield or the Caribbean? Or?
I'm at the Caribbean will be next week, but today it's Richfield.
Oh. Got it. Oh, it's close.
We love beach scenes. We would love to have you join us.
Yeah, please video in next week. Please.
That's a no way in hell.
Boy, true statement. And hey, Jim again from up in Bemidji. Thanks for joining us. I know you guys have quite the program going up there. So I have no idea how many patients you have up in Bemidji right now. But I'd love to hear more. Hey, Kelly. Kelly Logue's coming in, and hey, Becca Wen from Hennepin's opioid treatment program. I think for the purpose of time, we'll start rolling. I know people usually keep popping on for the next few minutes, so we'll kind of circle back and do some of the other announcements in a little bit. But for the sake of just kind of getting things going, well, first off, let's just introduce around the table. Cam Weaver just left. He's a psychologist here in the primary care behavioral health, who also has a background in substance use treatment. I'm Brian Gran. I do both primary care here at Hennepin Healthcare, as well as the medical director for the addiction medicine's office-based services.
Nathan Erickson, drug and alcohol counselor in the addiction medicine clinic here at the hospital.
And Tim Carrera, I'm the registered nurse care manager for addiction medicine, OBAT clinic.
Delani Dinaga, nurse practitioner at the interventional pain clinic.
And Roxanne Kibben, project coordinator.
So thanks everyone for joining. For the purpose of kind of, if you wouldn't mind just pulling up the other slide, T. T. Cook is our IT extraordinaire who's always behind the scenes that you rarely ever get to see, but I swear to God, he's making everything happen. Today, Nate's going to be presenting on the difference between 245G programs and OBAT, which you're probably like, what the hell does that mean? That's the point of why he's talking about it. And just for the purposes of a quick reminder, everybody, it's most helpful if you manage the sound on your side because the mic's pretty sensitive. So if the mic picks up any sound on your side, it'll cut to you as opposed to whoever is speaking at the time. And it's easier for you to mute and unmute yourself than for us to do it because we just have to guess when you may or may not want to actually say something else. Please, as much as possible, join us by video. It's always just nice for folks to be able to see who they're talking to. We don't mind people eating, and in fact, encourage it. Beyond that, that's the gist. We can kind of take everything else as we go. There's a bunch of actually really great talks that I'm super excited about for the next month. That's into the presentation. Anyways, so next week is Dana Slade is going to be joining us on medication disposal. So she'll be talking about a variety of different reasons about what's coming up. The week after that, it's going to be Nicole Kosanke. Nicole is actually a Minnesota native who now lives in New York City at the Center for Motivation and Behavior Change, which has put out, it's one of my personal favorite books around substance use, particularly to give to patients and their families in particular, using community reinforcement strategies around helping people with substance use, but also gives really great language around how to help set up contingency management in the home. which is something that if you missed it, you can go to our website and look at the slides from Cam's wonderful talk. You won't be able to hear his lovely voice, but we haven't gotten the video up. But if you're interested in hearing the video or sharing it, you can actually ask us for any videos of previous cases, and we can send you the video. We just can't post the video. But if you're ever interested in you or your colleagues reviewing or hearing something that's been talked about, you can always ask us for the video and we can deliver that now. After that, Ann Pilkus from Health Partners is going to be joining us again. She's going to be talking about kind of the nuts and bolts of how she does tapers from high-dose opioids onto buprenorphine. So it's going to be a two-part series. It's going to be her and then somebody I'm blanking right now, and then she's going to come back and bookend it. And then on April 18th, I can't miss, Dr. Kaz Nelson. She's a psychiatrist and she's the director of medical education at the University of Minnesota, has an awesome talk on borderline personality disorder. I think that's one of the most frustrating things that people deal with, just the emotional reactivity and the shifts. It's incredibly frustrating. She has an amazing way of thinking about it and talking about it and helping support patients. So I really hope that you can join us on April 18th. But I think all of those, I'm actually really psyched about the next 5 or 6 weeks. So I hope you can join us. With that, I'm going to pass it off to Nate, who's got the talk today on 245G versus OBAT, and what the hell does that mean?
Thank you, Brian. Trying to get my clicker online here. Excellent. Okay, so today we're going to talk about 245G versus OBAT, and that's really wonky kind of language there. And I don't like to have to use that kind of language where it's not immediately obvious what I'm talking about, but I think this could help everybody who's in sort of like an OBAT setting, or people who aren't very familiar with CD treatment as it's done in Minnesota, kind of get familiar with some of the language around CD treatment, which is now 245G programs. Talk about the language around them, what they're like, the differences between a 245G or CD treatment, or nationally an OTP, a methadone program. 245G is like a methadone program.
Yep, and so OTP, just to call the acronyms, OTP is opioid treatment program, which is equal to methadone program.
Yes.
Which is equal to a 245G medication-assisted treatment program. So this is like the word soup that gets really confusing.
We're going to do some word soup today.
Perfect. Versus OBAT, which is office-based addiction treatment.
We'll begin to understand the differences there, discuss the indications for differing levels of care. We'll talk about if it is even right to think about it as a different level of care, because I don't know that that's necessarily the case, and I don't know that it's being used like that in Minnesota. And then lastly, identify some shortcuts to communicating with methadone programs, OTPs, or 245G, as it's known in Minnesota, programs. All right, first up, substance use reform is happening right now in Minnesota. This is my picture to sort of describe how I feel about it. It's like Joan of Arc, crushing whoever, the English. I think that was 100 Years' War. Anyway, some wonderful heroine is here to save the day because things are dire, right? But this is more what it's like right now. Right now, there's a parallel process happening. So there's old rules around CD treatment, and then there's new rules. And right now, both sets of rules, are happening at the same time. So like all good bureaucracies, everybody's doing what they're comfortable with, and they're all doing what they did before, from my perspective. And I should say I'm not a policymaker. I'm not really involved in that kind of level anywhere. I'm just a drug and alcohol counselor who likes working with this population, and I've been doing it for 10 years. So it's kind of like a view from the bottom of the hierarchy, the following talk. I should also say that the following observations and opinions are my own and not necessarily those of Hennepin County Medical Center. So substance use reform, and what the heck is 245G? The two main things to think about for substance use reform are this move away from what's known as episodic care into a longitudinal chronic disease model. So that's one of the main pillars. Also direct access there, which means you can get right into programs. So what do I mean by episodic care versus longitudinal? The way CD treatment programs have been run and thought about in Minnesota, they're very constrained in that they don't share information outside very well. CFR is the rules around information sharing for drug and alcohol treatment programs. So they're inherently insular, trying to comply with their requirements for confidentiality. And two, they always have a set number of days that they're funded for. So most commonly, CD treatment programs were 30 to 90 days. And the big knock from the federal government and from other people in the state against Minnesota's treatment programs is that they're only treating people for these short periods of time. And they're kind of conceptualizing it like these people are going to be cured when they walk out the door. So there's not a lot of great follow-up afterwards when people leave CD treatment programs. It's not the emphasis. Like coordinating with primary care is not the emphasis. And that's the direction that substance use reform is trying to bring the state. So big thing there. We're trying to think more about it as a chronic disease model and not something that's short and cured quickly. And direct access is another great thing that's built into the system now, hopefully, although I don't see this happening. Ideally, someone who's looking for methadone, for example, in a 245G program could walk in the door and say, hey, I'm looking for this. They could do an assessment there and get started right away, not have to go out and get a separate Rule 25. So things are changing. It's moving away from the old system where you needed a Rule 25, and there's a big delay to getting into treatment. It was passed in 2017 and approved in August. The other four sort of elements to this reform that are worth mentioning is that there's going to be funding for comprehensive assessments, for treatment coordination, which wasn't separately funded for in these programs, for peer recovery support services, which is a really, really great thing. And it's been a while that the state's been trying to put this into practice. I don't see it happening a lot out there. But these are people that would be great to have in CD treatment programs. And then in July 2019, I think withdrawal management will begin to be funded as well. So substance use reform is happening in Minnesota. Things are changing, but it doesn't appear like they're changing in practice very quickly. So when someone says 245G, what are they talking about? It's just the license requirements for the CD treatment programs. OTP is sort of like the national term for methadone program, an opioid treatment provider. So if you hear somebody say 245G or OTP in Minnesota, they're talking about the same thing. They used to be known as Rule 31 programs. Rule 31 was the licensing requirements that have now become 245G license requirements. So there's been changes, but it's broadly the same. And then this shouldn't be confused with a Rule 25, which is the chemical health assessment the state has been using. Now, you can do a comprehensive assessment or a Rule 25. In the future, once this reform is done, when this parallel process is over, I think it'll just be comprehensive assessments.
Hey, quick question. Do you know when that change is happening, when it's supposed to be finished, finalized?
Sometime in the next year or two. I think the quote parallel process goes on for a while.
That's been being said for about 2 years.
Okay.
So we're waiting.
I would just go back to my Homer spinning in the nuclear control room there. I mean, it's not people. I don't hear people talking about it from my position, sort of as a trooper on the front lines, just working with people. I don't hear people talking about it very much. So that's what 245G is. What makes it a higher level of care? Now I'm talking about the differences between a 245G program and your typical OBAT program.
Meaning like what you could offer in your own clinic.
Right. If we think about it, as I think Vermont does, that these OTPs or 245G programs are a higher level of care, what makes them a higher level of care? How is it more structured than your OBAT setting? Well, the first obvious thing is dosing attendance requirements. So when somebody's on methadone, they are required to come to the clinic 5 times a week off the bat. And the logic for that is, I think, mostly that methadone is a public health risk, and you need to build up a certain confidence that your patient's going to meet certain criteria, basically keep their methadone safe and be safe in their community with their methadone. That's called the 8-point criteria. We'll get to that next. The 8-point criteria are what we use to evaluate whether a patient is ready for additional takeouts in our clinic. But I think this could be extremely useful for people who are practicing in an OBAT setting. You this is sort of like a rubric for understanding somebody's stability. What kind of things should I be looking at in my patient to know if they're doing well, if they're not doing well? And here, I think it's just broken down in kind of a nice way. If people who are working in the OBAT setting are aware of these 8-point criteria, you can kind of just use this to assess a patient and sort of how comfortable you are with where they're at. You can just read them for yourself here. We're always considering this when we consider takeouts for methadone. So this is what's known as the 8-point criteria. What else makes 245G a higher level of care? So counseling is built into that. An LADC meets with patients 1 time a week for the first 10 weeks, and then 1 time a month thereafter. Assessments, treatment plans, and progress are all based on the ASAM criteria, the 6 dimensions. So 245G programs, you could think of them as a higher level of care. Increased attendance requirements and this meeting with the LADC, 2 of the main things. I'll briefly touch on the 6 dimensions. I'm probably the people listening are familiar with this, but this is the sort of the ASAM criteria. All treatment planning in CD treatment programs is sort of based off this. The Rule 25 is based off of this. The comprehensive assessment, it's basically 6 dimensions of assessment to kind of get a full picture of what's going on with the patient and to guide you in treatment planning and placement. There's a matrix, which I didn't include, a state of Minnesota matrix. Everybody gets a score in these dimensions, a 0 through 4. You can look up that matrix with the state of Minnesota and see the exact definitions. But generally, 0 is low risk, a 4 is the highest risk. I think the biggest, probably the biggest hiccup for people with that is they think of it as sort of like a clear progression from 0 to 4, but it's not the case. It's not just like steady increasing levels of risk. There's actually different definitions for each score. So you kind of do have to look at that matrix if you want to start scoring in this 6 dimensions.
And just to give a background, ASAM is the American Society of Addiction Medicine. And so this is the guidelines that they created to guide what are the standardized guidelines for appropriate levels of care. So this is what most insurance companies are also basing their determinations off of.
Not something you would use typically in an OBAT setting. Like you probably won't run across this, but if you look at any chemical health assessment, any treatment documentation like progress notes or treatment plan reviews, you're going to see this 6-dimension language throughout. So just something good to know about from the OBAT perspective. This is a brief summary of what I've just shared. OBAT, you could think of it as a lower level of care. Buprenorphine is what's offered. Other things too, I suppose, but mostly buprenorphine. And then 245G, or an OTP, we could think of it as a higher level of care with stricter attendance requirements, with the counseling and the availability of methadone in addition to buprenorphine. So how to choose. This is the Vermont Treatment Needs Questionnaire. This, and I'm sure Brian or Tim might know more about this than I do, but this is a brief questionnaire to kind of guide you in placing somebody either into a OTP/245G program or OBAT. And you can read there on the left of the slide sort of roughly where the scores line up and then what the suggestion would be. And in Vermont, they refer to OTPs as sort of hubs, like the central or more complicated level of care, and then OBAT as a lower level of care. But I don't see this happening in Minnesota. I don't hear of a lot of OTPs transferring people to, or a lot of OBAT providers transferring people to OTPs and back and forth.
And what happened in Vermont, what's unique about it, they had a Medicaid waiver. So they have a smaller state, so they created 4 opioid treatment programs that were regionally located. And so then they all had to become medical homes. And so then they had a flow then based on their Medicaid waiver so that you could easily transfer somebody into and out of an OTP to a primary care setting where they would prescribe buprenorphine based on this criteria. So they would do kind of e-consults for people that were in like that 11 to 15 range, or like 6 to 10, depending on the comfort of the primary care provider. Anybody that was 11 to 15, oftentimes they'd start in the hub and then be transferred out. Or if they were 16 or higher, then they would always just stay in that opioid treatment program hub. Whether or not they were in an office-based setting or actually in the program itself, they had a lot more flexibility. In the state of Minnesota, because there's no medical home, essentially opioid treatment programs, in large part, with us being a partial exception, will only provide methadone. Hennepin is able to provide other medications with their methadone that they can pick up, but any other OTP in the state, all you pick up there is their methadone, so it's dose and leave. There's no other treatment coordination. And because of that and some of the financing for it, then usually an OTP doesn't break even until about 6 to 9 months. So most OTPs are very hesitant to discharge people or to accept people on a shorter term when they're not sure what the flow is going to be. And on top of that, then the 42 CFR, that federal regulation around privacy issues, which makes it even harder to share records. It makes it harder to coordinate care between an office-based and an OTP.
For
So
sure.
it's harder to do that transition.
Thank you, Brian. That's good background on sort of Vermont. And I guess the question for the group and for all of us is this something we want to be doing? Do we want to be taking our higher risk patients who maybe aren't working in the OBAT setting? And do we want to be partnering with OTPs who are near us and transferring people? And then do they want to go the other way too? If we have people who are in 245G OTP programs who are on buprenorphine, once they reach a certain level of stability, do we want to be more active in transferring them to an outpatient setting with less attendance requirements and just less burden on the patient? So I think that's sort of the background question I'm asking myself throughout this talk is, like, should we be doing something closer to what Vermont is doing? Does that make sense? And is anybody doing it out there? So I welcome anybody's feedback if they're transferring people back and forth, or if they think there's like room for that for them, or if it's needed.
I use this when I get phone calls from patients interested in our program. I run them through this questionnaire. And if it's higher level, like numbers are getting up there, then we have a discussion about whether that patient would work in our program or not.
Like a screening tool?
Yeah, I use it as a screening tool.
And the other big barrier for OTPs is that right now most Medicaid products will only cover methadone because of the cost difference between methadone, which is like less than 10 cents a dose, compared to buprenorphine, which is like $8 per pill. So they will offer it, buprenorphine, in most sites. However, in most private sites like Valhalla and others, if your insurance won't cover it, then you have to self-pay for buprenorphine. Otherwise, you're forced into a methadone setting. So if you don't want to be on methadone for whatever reason, then you have limited options in an OTP.
Here is a map of the OTPs, 245G programs. There's also one in Brainerd, which didn't make it onto the Google quick search that I did, but you can see that, unlike Vermont, apparently things are not spread around very well. There's whole sections of the state where you're not going to have anybody to partner with. So what to do in those cases too, if you feel like you have a really high risk, high need patient who maybe isn't working in the OBAT setting, if you don't have anybody else to refer to, what are you going to do? What techniques can you use to try to keep them? I think those are sort of topics for another day that I'd like to get into. Here's my GIF about 245 CFR 42. Okay, so when you talk to a CD treatment program, if you get this energy from them, it's not just you. Okay, it's like this for everybody. CFR 42, and this is where maybe it gets into my opinion a little bit, but I think it's profoundly affected the way CD treatment programs interact with everybody else in a bad way. And I think it's 30 years old. So, I mean, that's a long time for me for something. And it was just updated. There was some updates to it last year. It does make provisions now to sign a broad release. You can sign a broad release giving you authorization to talk to all your medical providers, for example, where you don't have to get separate releases for each department or each physician you talk to. So this is something that can help you when working with a CD treatment program, 245G program, but don't be surprised if you get a cold shoulder when you try to call them and talk about a patient. They're going to have their own releases, CFR 42 compliant releases, which are different than your typical medical release that you probably use in a hospital or whatever outpatient setting. So if you call and talk to one of these programs and you get the cold shoulder at first, you just got to keep trying and get one of their releases. But CFR 42, I mean, I think it's the biggest barrier to integrating CD treatment to medical care. Honestly, if this is the one thing that, in my mind, like needs to change nationally, because this idea that CD treatments are doing this short-term episodic care, totally divorced from like the primary care world and all other medical providers, psychiatrists, psychologists. CFR 42 is the #1 barrier to good patient care, in my opinion. I'm not sure the hospital is like on board with that, but I think it's a huge problem.
I find it a huge barrier.
And if you want 42 CFR compliant language for your own releases, contact us and we can share the language that we've got created for ours. So you can just adapt that and put it onto your form. Many people are specific to their own form, but they shouldn't be. But we can give you the language to make any HIPAA release compliant with 42 CFR.
That can be really useful. Here's my tips for talking to 245G programs. If you could remotely construe it as a safety issue, ask for a supervisor. The front desk at these programs could be manned by anybody. It could be volunteers. It could be like chemical dependency technicians. It could be anybody at the front desk. And they're universally educated and taught by their management, I would say, to not talk to anybody under any circumstances. So no matter how compelling your reason, or if you have the patient there on speakerphone with you even, they might not be willing to talk to you. So ask for a supervisor if you ever need any. If a situation isn't typical, just ask for a supervisor. Don't even waste time at the front desk because they're not given the authority or latitude to sort of accommodate you. Well, this bullet point didn't make it on here, but I think another super key thing when working with 245G programs is to try to develop relationships. I mean, talk to people in your community, whatever treatment programs around, get to know the front desk, get to know the admissions counselors. If you can create relationships with your local treatment programs, you're much less likely to have trouble with the cold shoulder, the CFR 42 cold shoulder. Those are the two main tips I have for 245G programs. Ask for a supervisor and create relationships. So this is the part where I wrap it up here. Tentatively suggesting maybe to think about 245G as a higher level of care. Should we be doing it more in this state? And how do we decide if a 245G program is the right referral? And I'm going to leave it there with kind of a question. So I think it's up to us, to you guys, to think about how we want to be doing this going forward.
Yeah. Any questions folks may have for Nate on the topic? I think this is oftentimes an area of confusion.
I don't have a question really, but just more like a comment answering your question.
Perfect.
So when I was training in residency with Bob Levy, our plan was always told to escalate care to a methadone program if Suboxone wasn't working. But I've actually never done that here at North Point. It just hasn't been the right choice for any of my patients. None of them have been interested at all. We've gotten 2 patients from methadone programs.
Okay.
Neither of them, well, one of them's doing okay and the other one's not. The other one we haven't seen in months. She was an alcoholic. So, yeah, that's just our 2 cents. I still think it's a good idea. It just hasn't really happened. And my patients aren't interested in it.
Oh, yeah, and I wouldn't expect they would be with the increased attendance requirements and all the other hoops they have to jump through. So, yeah, that makes sense. Thanks for sharing. Anybody else questions on, would you use a OTP, a local OTP, or do you think it's right to think of it as a higher level of care?
I think to share my experience with it, I think OTPs are appropriately thought of as a higher level of care for certain people when there's a particular high-risk situation, because then you have eyes on the person more frequently. So I think that's when it becomes more of a necessary situation, particularly when there's, because I think in terms of the criteria for office-based that I think are most important is you have to be able to show up to appointments. If you can't show up to appointments or it's always completely random when they're able to show up, then the OTPs is much easier because you can show up essentially between 6:30 and 1 o'clock and dose that day. So in terms of people that have lots of chaos in their life, it's really easy for them to just kind of figure out when am I going to show up to dose, and that's just kind of how it's going to work. If they really struggle showing up at like 3:20, on a Thursday, or they continually lose their medication, and then you're talking about early fills, which is never comfortable, and it has to be really clearly defined rationales, and that's when you kind of run into problems. I've been surprised at some of the people that stabilize in an office-based setting, but I've definitely been impressed by who doesn't. So I think oftentimes the way that I do it is that if people really refuse an OTP for whatever reason, oftentimes I'll give them a month trial in the office-based setting, and if they really can't follow up on appointments, they're coming in or missing appointments or calling in, they have to get reschedules and missed doses, and then it's just like, this isn't working out, and then it's a transfer. From my perspective, I think going the other way, it's usually patients that are just sick and tired of the methadone deal for whatever reason. Sometimes that's where it's really hard to get the records from the OTP, because sometimes people say, like, I want to be done with that because I'm still dosing 6 days a week. If that's really the issue, then there's probably a reason why after like a year that they're still dosing 6 days a week. That's like the single biggest indicator. If I meet somebody that says they're in an opioid treatment program that wants to be off, ask them how many days a week do they dose. If they say 5 or 6 and they've been there for many months, there's reasons why they haven't progressed along those 8-point criteria that somebody thinks that they're still really high risk. That's probably not going to be somebody that's going to do well in your office-based setting. If they've been there and they're dosing like once every 2 weeks or once a month, it's probably reasonable for them to transfer out. I think the harder thing in that standpoint, though, is that those are the people that the OTP, in the state of Minnesota, you get paid, it's approximately $12 or $13 per dose. So those are the people for whom the programs are getting the most money, are the people that are really stable, because then you get paid per dose. So then they're getting 2 weeks of payments for only having to see that person once every 2 weeks. So that's where oftentimes it's financially makes sense for people to be in the program for 6 to 9 months before they ever have a return on the investment for the program. So I think that's where programs don't like to give up those patients, but those oftentimes as a health system, they make the most sense to be in your clinics. So I think that's kind of where you can kind of think about if somebody presents to you, how do you think through that patient? Should I or could I transition them from an OTP setting to an office-based setting? Feel free to kind of ask other questions, but I'm going to kind of move on. A couple other announcements now that we have a couple more people joining us, and then we'll kind of move on to the case for today. Just to kind of review, there's a couple people that joined us afterwards. So hey, Celia. I think Celia is joining us from Golden Valley, from Hennepin Healthcare. Hey, Brittany Dolan from the Minnesota Association of Community Health Centers. Hey, Alyssa, I think you're also joining us from up in Bemidji. And I think there's a couple other people. Hey, Ray Christensen, how's it going? And I don't know who Kay Farchman, I'm not sure who that is.
That is
So welcome.
Kurt. Kurt. It's Kurt Farchman.
Gotcha. Hey, Kurt. And hey, Lauren. I see Lauren's joining us as well. Couple things we just wanted to pull through in follow-up from our conversation last week. Some of you may have been on, some may not. We were talking a little bit in the morning. One of the goals that we have, just to kind of make it explicit, part of the reason we're funded by the state is to try to help people and mentor you to be able to build your own capacity across the state to prescribe buprenorphine and care for people. As part of that, where the most success in the ECHO model has been is when we can really help you and mentor you through your own process in terms of how you're taking folks. Oh, hey guys. Hey, Kurt from Grand Marais. I didn't recognize Kay Farchman. But part of that process is helping mentor, and part of the tele-mentoring process is helping you work through your own patients. And I just want to be explicit, that's part of the reason that we're funded to be able to kind of be here on ECHO, is to help you expand your own treatment capacity. I know that people have lots of different reasons you may be tuning in, sometimes just for education, sometimes it's to actually get help with your own patients. There's lots of different reasons. So I just wanted to call out one of the things that we just have never actually checked in on is actually to ask that question is, what do you want to get out of ECHO? So that way we can kind of go to the state as they're right now considering whether or not to refund us starting May 1st and on, is what can we really offer you that you're most interested in? So in the email that you got from Roxanne reminding you for today's session, there's a link to this poll, this doodle poll.
This is actually on their screen now.
This is on your screen now. So it's one, just kind of asking, what are you looking for in ECHO? And whether it be passive education, whether it be specific mentoring and case-based learning or something else. If it's something else, please just send a chat to Roxanne to see how we can help you out. The other thing that we've heard kind of mixed opinions about is sometimes people are really looking for those case-specific discussions instead of the didactic. And I know at 1 o'clock, oftentimes there's a time pressure for seeing that 1 o'clock time slot as a patient, depending on whether your clinic managers carve that out for you or not. So the question is, would you rather us do the case presentation first and then the didactic, or continue with the didactic first and then following up with the case afterwards? So that's just going to make a big difference for us, and maybe you just don't care, that's cool. But just helps us kind of make sure that we're meeting your preference and what your needs are to be able to support you. So let us know if you wouldn't mind just taking the time for that. And part of this too is that for that mentoring and case-based learning, it's always best, at least from my experience in training and my ongoing education, whether it be like coaching or whether it be through mentoring, is to actually have that discussion about my patient and to explicitly say what my thought process was. Because oftentimes, I don't know about you, but I think I know the answer, and then somebody asks me to articulate why I think that, and I realize I have absolutely no idea why I think that, or actually I have no idea. And until I'm actually forced to say that out loud, I don't even realize that I have no idea what I'm talking about. So I think that's part of the mentoring process that's particularly helpful. So if you're interested in that mentoring, please, please, please let us know, even if it's like you've got one case that you're not even sure if it's the right kind of case. I think that's where we're all in a different spectrum of where we are in us doing this. So please let us know if you have a case that you can present, because that's where you're going to get a lot of the meat out of it, and how I would like to be able to support you in doing this at your own clinic. So let us know on those two. And if you say that you're interested in mentoring, please reach out to us if you have any cases. The nice thing that Roxanne also set up and sent out to you this week is that we've switched, instead of having a case form, she kind of put on a SurveyMonkey. All the things that you would have on a case form, you can just go to SurveyMonkey and it's just right there. So we're trying to make it as easy as possible for you to send in the case details. All this, remember, is de-identified. So like 32-year-old male, and then everything else is vague. And we can kind of fill in the details in the part of our conversation. But part of the way that we can do this education and mentoring is to have no patient-specific details. So you'll be able to follow that link to SurveyMonkey to just put all your case presentation up, but hopefully that makes it as easy as possible for you to put in details. Even if it's like, I just saw that patient, you can fill in the SurveyMonkey instead of waiting 3 weeks to fill out some form. You can always just send it in to us, and then we can kind of discuss it as it comes up. So think about it, let us know, but hopefully this will make it a little easier for you to send in cases when it pops into your mind when you're seeing folks.
You should also have a doodle poll for me that I'm asking for the next 6 weeks for people to sign up. If you're available to do a case, we will get back in touch with you to make sure that you are confirmed for that date. But please sign the doodle poll on when you would be available to do a case. That should be coming in your inbox very soon.
Great. With that, thank you for your thoughts. We'll kind of take this into consideration, kind of reach back out to you if it's appropriate, but we'll move on from here to the case for today.
And the polling now.
And the polling now. Please do the polling now if you have a moment. You can kind of see it. Then we'll be able to kind of follow up with you or kind of change things up in the weeks to come.
Okay.
Great. Thank you for your feedback. I really sincerely appreciate it. T, would you mind switching to the case, please?
Maybe it's asking for me to do that. So let me share my. Okay, just a moment. You have it, T. There he goes. Okay.
So this is a woman, kind of case again, who, as I'm sure is not an uncommon thing, is struggling with both opioid and methamphetamine use disorders, as well as some other social chaos. So this is a 52-year-old woman that I've known for over a year now, who has a past medical history significant for PTSD, major depression, opioid and methamphetamine use disorder, long since sustained recovery from alcohol use disorder, has been struggling with homelessness, domestic violence, and sexual assault, who until recently had a 2.5-year history of abstinence from methamphetamines. So when I first met her, I started her on buprenorphine for opioid use disorder while she was still homeless, but was in a shelter. And then kind of off and on for about 8 months, she was transitioning between shelters and living with her daughter and her son-in-law. Her son-in-law struggled with an alcohol use disorder, so daughter was struggling, so intermittently she would be in shelters and with the daughter as she was trying to seek a housing voucher. And so part of getting a housing voucher, you had to be homeless in shelters for a certain period of time for where she was going. She finally got a housing voucher that was accepted in Sherburne, Stearns, Wright, and Benton counties, even though she was staying primarily in Hennepin County, but she was bouncing back and forth between daughter's residence and shelters. But where she ended up getting the housing voucher was up in those 4 counties, or that was where it was eligible for. She finally got an apartment in St. Cloud, and so because it was independent housing, she moved up to St. Cloud. And unfortunately, after all this time being absent from all illicit substances, doing really well, she was actually she led an AA group near where her daughter lived. She moved into an apartment where her neighbor across the hall was a methamphetamine dealer. So he helped her move in, seemed really nice. Then later that night, he said, "Hey, why don't you come over?" She walked over. He disappeared into the bedroom. A couple random people walked in and out, and then he came out and he was like cooking some heroin, and he said like, "Hey, I think didn't you say that you once knew how to do this? Could you show me how?" And then continued to kind of then offer her repeatedly methamphetamines. As you might imagine, for a while she stayed sober, and then intermittently now, because it's so close and proximal, that's her main social support there. She's now returned to intermittent methamphetamine use. And she fears then for a return to homelessness. So part of the issue now is how can she get a new apartment but she's on a voucher at the same time trying to stay absent from methamphetamines, now struggling with this tension. Unfortunately, she was a lot closer when we started this, but now that she got housing in St. Cloud, she now drives from St. Cloud every couple weeks down to see me in Minneapolis. I would ideally, if she lived closer and she had more consistent transport, I would have her coming once a week, give her methamphetamine to kind of titrate up the dose of therapy that we can provide. Unfortunately, given the transportation difficulties she's had, she recently lost her car, or access to her car, so it's just much harder for her actually to get here. You can kind of see there her past medical history, nothing major, some chronic pains. She's got depression on sertraline or Zoloft. Previously met with a therapist weekly, but then the therapist stopped practicing up in St. Cloud, so now she doesn't have one. She's interested in meeting with her psychologist here at Hennepin, but again, it goes back to transportation, so she may not be able to see him regularly. She's a cigarette smoker, but otherwise denies all their big family history of substance use disorder. So that's kind of where she's at. So I think the questions that I had for the group that I think that are common and generalizable is one, particularly when you're struggling with distance or transportation, how do you titrate up therapy when people may or may not actually be able to come to your clinic so often? And then two, it's how do you really struggle and manage that methamphetamine use with somebody who's coming to your clinic? And I think those are two really common situations. So first up, any questions that people may have about this case?
Is the PTSD related to the sexual assault history, or did it predate the sexual assault?
It was a combination of sexual assault and physical violence as part of domestic abuse.
So those will go all
Physical and
together.
sexual.
Okay. Ongoing?
No.
Okay.
The last time she had any assault was about 3.5 years ago,
Okay.
while she was homeless on the street prior to getting into the shelter system.
Ron,
Yeah. Hey, Marshall.
Brian, how expensive is a methamphetamine habit, and how much income does she have?
So she's right now on, I don't remember off the top of my head if she's on general assistance or as SDI. She actually rarely ever pays for the methamphetamine. It's just her neighbor is the dealer. So he says, hey, do you want to just come over and have some with us? So it's almost always free. In fact, her last use was one of the two neighbors ended up going to jail for a while. And the other one offered her methamphetamines to drive her car to pick him up from the jail. And so she got essentially three kind of points of it. So she got 3 quantities of methamphetamine in order to kind of do this favor for the dealers who is friend of the guy in jail.
So there's no hardship.
Marshall, this is Nate. That's a great question. I'd say amphetamines are one of the more affordable habits to have in that the effects last a long time, and depending on your route, if you're snorting it or if you're injecting it, it's one of the more affordable ones. Like a powdered cocaine habit's a little more expensive. So just anecdotal there, kind of.
Has she mentioned safety concerns? Does she fear some kind of retaliation if she were to not take the guys up on their offer of free meth? Or
no, she in fact thinks they're quite lovely. She actually recently, now to her chagrin, agreed to put her name on the title of a car that one of them was buying. She has since rescinded that because he drove away without a license on the car that she put her name on the title to. So again, she lacks a bit of insight into the risks that she faces. But she overall finds them nice guys that she likes to hang out with.
What did her 2.5-year history of sobriety look like? What was happening in her life at that time?
She's homeless between the shelter system and her daughter's place, and found that she just really needed to get sober because the substance use was very intertwined in the domestic violence. And then getting out of that situation with her using ex-partner put her in a much better place. And then she got very involved in her church and in different AA groups, which she found to be a very positive, reinforcing environment and community. And so she really loved that. And then unfortunately, the housing voucher took her out of all those supportive communities and put her up in this apartment in St. Cloud next to the dealer.
Okay.
Has she had a chemical health assessment, or has she ever been to CD treatment?
Many times in the past. Not currently. She's worried that if she were to go, because when we've talked about options for housing for her, since she has now returned to use for methamphetamines, we could make an argument around would residential be helpful for her. Overall, in the ASIM criteria, she doesn't totally need it for residential, but you can make the argument. But in this case, she's afraid that if she goes to residential, she would lose the voucher, and then she would lose all chance of housing after the fact. So she's not interested in residential because that would put her more stable housing at risk.
Yeah.
And so now she's interested in trying to change housing without having to go to residential.
Was she high at the time of the motor vehicle accident?
She says no. She said she was just distracted driving, looked down, lots of traffic, rear-ended a guy, and her front of her car accordioned.
Okay. And you said she has seen a psychologist in the past, but they retired, right?
It was a therapist that used to be somebody she worked with, who was, I think, a social worker who was doing clinical therapy in St. Cloud, had briefly opened doors to seeing patients, couldn't afford the office space, and then closed his practice. So she only saw him for about 2 or 3 months on a weekly basis. So I'm not sure the quality.
Sure.
And now she doesn't have anybody.
But did see primary care behavioral health here? One time.
So if, say this patient showed up, I don't know if you've had situations like this, Helen, what would you be doing with this guy if he showed up at North Point?
Yeah, we see a lot of people in this situation, you know, and it's extremely frustrating with the combination of the social issues, the housing issues. Yeah, I don't have anything that I have to offer. I'm sorry that I would do extra.
Well, I guess the question I would, you know, and I'm curious for Dr. Courser and Alyssa up in Bemidji or Natalie over in Richfield. You know, I think this is one of those cases where I think everybody's trying to figure out the right approach for how to support these people. You know, I've had experiences with some providers where they say if you have 2 positive urine drugs for something that's not prescribed, then you're out of the program. I find that less helpful because then you lose them completely. And I don't think the evidence necessarily supports it. But I think that's where kind of that tension between how do you support these people in an appropriate way. And that's why I'm curious, how do you support these folks in your clinics? Natalie.
I think we give them a lot of leeway. And I remember when I first started doing this last year, my mantra was, I am better than heroin. Suboxone is better than heroin. Whatever I'm giving them is better than anything they can get on the street. So when people come in, and I've seen a really nice progression, a lot of them, where there'll be 3 or 4 things in the urine, and then it'll be down to 2 or 3, and then it'll be down to a couple, and usually there's still marijuana, but even a few people have stopped that too. So, you know, the new saying is that relapse is the expectation, not the exception. So we know this is going to happen, and especially my heart breaks for this poor woman who got put in that circumstance. I would say, we have a social worker, let's talk about new housing so you can escape that environment, because the environment is setting you up to fail.
How often would you be seeing this woman, Natalie?
It's hard when transportation is an issue. As often as I could get them to come in, and if it could only be every other week, then that would be it. Maybe we could do a phone check-in or something in the meantime. I wish there was a Hennepin in other cities so we could say, I'm going to order the urine test and you can just drop it off in St. Cloud or wherever. I don't know if that something like that could be arranged so that they have some kind of accountability, even if it's not coming to the clinic.
She could save herself 30 minutes, maybe more, if she stops in Brooklyn Park to do something similar to that. You know, yeah. That's our farthest satellite.
It's true.
Yep.
What, Alyssa and Jim up in Bemidji, how would you guys manage this kind of patient?
This is Allie. Go ahead.
Well, go ahead, Allie.
Oh, well, I was just going to say, I kind of am on the same wavelength as Helen, because I don't feel like I have a lot to offer the conversation either, but I just wanted to say that we have a lot of patients who are in the same situation, but they've kind of been in the Bemidji area for years and they're very isolated. Like, we don't have a lot of people who get a housing voucher to go to like a different county because there's nowhere to go for like 100 miles, you know? So they would be like really relocating, and people are culturally afraid to do that because of like leaving family and everything they know and things like that. But we have quite a few patients who, you know, they have not had a drug screen positive for opiates in a very long time, who are just consistently positive for methamphetamines. And it's the same situation where their neighbors or family members or whoever are using, and they're coming into our clinic to get a dose every single day. And they're seeing Dr. Courser like once every 7 to 14 days. So yeah, I'm struggling with this one too.
Yeah, I mean, that's why I wanted to bring it up, because I think this is one of those super common things that we're all struggling with. And when you do that, that's interesting. So how do you do the daily dosing in clinic? Do you do like an in-clinic dose, or do you have them pick up from a pharmacy and deliver it and bring it with them, or how do you do that?
It's an in-clinic dose. So they have a nurse visit every day, like 7 days a week. And so there's like an LPN who does the nurse visit. And then I'm an RN case manager, so I'm available all the time too. So I'm working with them on housing pretty consistently. But I mean, it still takes like months with our community resources to get, you know, people situated in new housing. But it does seem like the common theme among people is, okay, so if we ask the question like, well, how do you, so your goal is to be in recovery, how do you think you could accomplish that? I mean, the overwhelming response is, I need my own housing. I need my own housing.
Yeah, that's interesting. I hear that. And just out of curiosity, the trade-off that you guys decided for daily dosing versus like giving them a few days or a week, how did you come to the decision to do daily? I think that's interesting. I know there's a number of clinics that are kind of debating between different models. I'm curious your thought process to come to daily.
Joe, are you still there?
Yeah.
I don't know if you wanted to talk.
So we started, there was a big problem with neonatal abstinence syndrome at the hospital here in Bemidji, and so we started just treating pregnant women, and so that's how we started this daily administered therapy with pregnant women, and so we've just kind of continued that model. We have so many people who are unstable. If we looked at that Vermont treatment needs questionnaire, many of our patients would be way over 16, and patients that probably shouldn't be treated in an outpatient clinic like we have, but they don't have transportation, they don't have housing, they don't have the wherewithal to get anywhere. And one of the reasons we started this clinic is because Beltrami County, where we're located, was spending so much money transporting people to the cities or to St. Cloud to receive their treatment, that was one of the reasons that we started this program. So we have many patients who continue to be unstable, and we don't feel comfortable giving them any take-homes except when the clinic is absolutely going to be closed on a holiday or something. And so we've continued to do this daily administered therapy.
Got it. Thanks for that take. That's really interesting. Yeah. Love to follow up with you guys offline about how that's working for you. So just to kind of take a step back, some of the medical evidence around other therapies that may be available for methamphetamine use. So big picture, there's nothing that's been consistently significant and positive results from randomized controlled trials. That said, there's really 3 medications that are out there that have shown hints of signal in randomized controlled trials. So to kind of put that out there, if you're struggling with where can we go next, that I may be able to have some intervention for some of these people, there's 3. One, there's been some study from signals from study around high dose extended release bupropion. So right now there's been a number of different trials that have looked at 450 milligrams of extended release bupropion, which have had really mixed results. But there's been enough positive results that people now, there's an ongoing clinical trial that's just finishing up using both Vivitrol, or the injectable intramuscular formulation of naltrexone every 3 weeks, plus 450 milligrams of extended release bupropion. So we'll see what the data shows on that. So 450 kind of max dose, even right out of the gate, you don't necessarily have to titrate up. People have tolerated it really well, just going straight to 450 of extended release bupropion with a history of methamphetamines. And for some people, that's been effective at decreasing their cravings for methamphetamine. Doesn't change the social situation, but it can definitely help with some of those cravings for some people. The other thing that people have explored, that there's some literature out there, is for topiramate. So that you really do have to have a titration up. So oftentimes starting at like 25 milligrams once or twice a day, and slowly going up by 25 to 50 milligrams a week, up to 200 to 300 milligrams total daily. So divided oftentimes to 100 to 150 milligrams twice a day. That medication, though, you really have to be consistent with it. Stopping all of a sudden, there is a risk for withdrawal seizure, although it's a very low risk, but it's possible. The most common conditions that people have with that is these kind of random paresthesias. Nothing permanent, but people will describe all sorts of things, from tingling in like my shoulder to, my leg feels like pins and needles and burning. It's just really all over the place. Sometimes it's a perioral paresthesia. And the other thing that oftentimes for about 40% of people feel this like degree of cognitive slowing, most characterized by word finding difficulties. So it's like people feel like they got something on the tip of their tongue, they can't just quite get it out. Interestingly, lots of times people just stop the therapy. There's more data to say that if you keep sticking at that dose for up to like 3 to 4 weeks, oftentimes about half or slightly more of the people will actually, that symptom will resolve, and they can kind of continue either at that dose or with dose escalation. So it's something to think about. And then the third option is Vivitrol, the intramuscular depot naltrexone. Obviously, if you're on an opioid right now, switching all of a sudden to that is really rough. So it's kind of depending on your patient population, what makes sense. That may or may not be an option. The data is most consistent for that every 3 weeks Vivitrol. Most insurance companies are not covering it every 3 weeks. They'll only cover it every 4. So then it's kind of adding on whether it be oral naltrexone for the 4th week or exploring that. So I think that's where it's really kind of trying to figure out where it is. I can send out references for those offline. I'm not going to kind of put them here, but I think it's really just trying to figure out how to do that. So if you want references, I can send that out. Otherwise, I think that's that. Beth had a quick question on the case, urine drugs for fentanyl. Yes, all of them have been otherwise negative for that. All of our urine drugs that we get have fentanyl, specifically as an immunoassay on there. Being mindful of time, I'll call it there unless people have other questions. I know this is a super common issue that everyone's struggling with, so please, I welcome your thoughts on the case or what you're doing to try to struggle with it. And then if you have any other cases that you would like to present or discuss, obviously we don't always have the right answer. This is an evolving field, but I'd love to kind of see how we can disseminate practices and even test things out across the state. So thanks for your time today. Look forward to seeing you next week, where Dana Slade's going to be joining us on medication disposal, different ways to do that that are clinic friendly. And please, if you haven't taken the time to go back to that SurveyMonkey link that Roxanne sent out to submit cases, as well as to let us know on those doodle polls. Have a great day, guys.
Brian,
Yeah, what's up? Alex, stick around for a while. Follow-up.
Sorry, I didn't quite hear that. Is it all right if I just add something about the case?
Please, yeah.
Yeah, the only other thing I was thinking, and I apologize, someone already said this, but for your patient in the St. Cloud area, you kind of mentioned that she lost all of her community from when she moved out of Hennepin County. And I was thinking back to a couple weeks ago when someone mentioned peer support recovery advocates. Mm-hmm. So I can't think off the top of my head what the resource is, but it's like a statewide resource where potentially they could find someone for her who would kind of visit her in her home and try to connect her with a recovery community, because if she's been willing to do it in the past, maybe she'd be willing to do it now.
So, great point. That's the Minnesota Recovery Connection. So it's minnesotarecovery.org. Just as last time when she saw me, she agreed to do the telephone reach out. So she filled out the form to do that. So I'm hoping she's coming back, I think, next week. We're doing like every 2-week visits that hopefully I'm hoping, like you said, that she has some telephone reach out that hopefully she can get connected. Great point.
Mm-hmm. I would also spend some time with her in a visit, looking at churches in the area, maybe like online or something, just to kind of get her back into those other supports in her life that kind of added richness and depth, because right now it seems like her life is pretty flat with just a little bit of connection across the hall. If you're having trouble finding good psychotherapy in the area, there are some good self-help books, which can be a nice place to start, that are, I think, more broad than substance use specific, but I think people can generally do well with them.
Do you have some titles?
Yeah. So if you feel like they benefit most from like your just kind of, typical CBT, good old-fashioned cognitive behavioral therapy, the Feeling Good Handbook by David Burns is a kind of a classic. It's a thick book, but it's very readable and very CBT focused. The one that I've been giving to a lot of my patients lately as a resource to kind of augment therapy between visits is something called The Happiness Trap. It's a self-help book, so it's got to have a crappy title. That's just like a rule. But it's based on something called acceptance and commitment therapy, which has been shown to be very effective it's really robust. It seems to work at almost everything we throw at it. Everything. It was developed around generalized anxiety disorder. It's been shown to be very helpful for substance use disorder, psychosis. It just seems to work. And it just takes a different approach to suffering, kind of incorporating traditional cognitive behavioral therapy with kind of an Eastern influence of mindfulness. And patients really seem to like it. Russ Harris, the guy who wrote it, studied with the guy who developed acceptance and commitment therapy and wrote this very, very readable, very easy book that you can kind of pick up, set down, get some really good nuggets out of it that are very kind of ACT, or acceptance commitment therapy focused.
Can we get a CAMS self-help recommendation list up somewhere?
Yeah, I think we could probably do that. I can make that happen. But it's called The Happiness Trap by Russ Harris. That's the one that I've been recommending the most lately.
Here's another one that they have, a quick question book title for CAM offline. Oh, okay.
So we'll get that to you, coming to you live, Cam's happiness list. It's his own little happiness trap.
My own little happiness trap, right?
All right. Well, thanks, folks. If you have any other questions, we can stick around for a little while. But otherwise, have a great day.
That kind of makes me sound like the Buffalo.
See you tomorrow.
See you, Haley. Look forward to seeing you, hanging out with you.
Like there's a pit or something. It's more of a happiness pit that I put like Buffalo Bill from Silence of the Lambs.
Cam.
Yay, hi.
Hey, this is Beth. Are you familiar with the book Buddha's Brain?
I am not, but it sounds like that it would have a lot of like mindfulness stuff in it.
You know, I think so. I keep getting it, and then I just end up giving it to somebody, so I've never read it.
You're a regifter. Got it.
And my understanding is that it explains sort of a physiologic way, so that, of explaining why we sort of have may have an anxiety response, or why we have that, and sort of the benefits and how to help manage that. I just wondered kind of what your take was.
So I think I actually, that's something I wrote down on my sheet when that we didn't get to, but the patient said that methamphetamine, she doesn't believe methamphetamines exacerbates her anxiety. And I see that all the time with patients, and so helping them kind of differentiate, sympathetic arousal and from substance intoxication, but also I think more importantly, recognizing that not all anxiety is bad anxiety, and that, humans have evolved to experience a variety of emotions, and that allowing those emotional experiences is really important. So, people who are born with that condition where they can't sense pain don't live very long, and they get injured all the time because pain is an important thing to be able to experience. Anxiety, there's a lot of research on like the arousal performance function and how a moderate amount of anxiety tends to be best for performance in a variety of different areas. Even things like sadness are human emotions that we should allow ourselves to experience. And so what I think that book sounds like it's getting at is kind of, hey, why does anxiety happen? Where is it coming from? But also probably recognizing that, hey, anxiety is actually facilitative. It's important. There isn't a single human emotion that we shouldn't feel. And my argument for that is if that was the case, then it either would have evolved out of our species long ago, or at the very least, you wouldn't be able to see it cross-culturally. I mean, almost every culture on the planet has the same core emotions that are expressed and easily identified. So it must mean that those emotions have a purpose. And it sounds like this book that you're describing is similar, that it might look at it the same way.
More articulately stated. That was how it was explained to me, exactly what you said in terms of why do we have these emotions, and this one in particular. But yeah, okay.
Yeah. So that book is good, and I would say that The Happiness Trap, acceptance and commitment therapy really is this really nice blend of like the behavioral aspects of cognitive behavioral therapy, like getting people engaged and moving and doing things and out there. But instead of addressing thoughts as these things that are kind of broken that need to be targeted and fixed and then replaced, it kind of gets rid of all that idea and says, hey, your thoughts are just that. They're thoughts. They come, they go, they can be allowed. But our efforts to change them actually are probably what keep them around. And so let's take a different approach. And the approach is a mindfulness-based kind of Buddhist approach to thoughts and feelings.
All right.
It's a good one. And it's super readable. It's the happiness trap. It's the happiness trap. And there's even for if you have patients who are not super literate but can read some, there is a graphic novel version as well. And it's been translated in different languages too. So.
All right.
That version.
Yeah.
Well, thank you.
Yeah, no problem.
Does it star Batman?
What's that?
Does it star Batman?
I don't think so. No, sorry.
So hey, Amy, Joe, Alyssa, are you guys still on? For any of you?
I'm Joe Corson.
Hey, Joe. So I'm really curious. We've kind of flirted with the idea of doing daily dosing in our clinic. From a financial standpoint, does that shake out okay for you guys? That's been our big concern from our admin is, could we do daily dosing, or would that saturate staff's time too much?
Well, Allie can speak to this a little bit better, but the Medicare payer for Northwestern Minnesota, Prime West, has been very interested in us initiating care for this patient population because of the amount of money they spend transporting people way down the road to get it. And so right now, when people come in and do daily dosing, they get buprenorphine and it's free to them. The hospital just supplies it. And I don't know that they get any reimbursement from Prime West right now, but so far we've gotten.
I think there's like a small, it's just a nurse visit, and I think there's like a facility fee that we charge or something, but I could get some more information about that, of how we do that specifically. And I think like, you know, like 99% of our patients are on, you know, Medicaid, but there's some that are not. But in terms of like your question of taking up staff time, I mean, the visit itself is quite short. It's like less than 10 minutes per patient, except that the more you see the patient, the more their issues come to mind and they want to talk about it. So, you know, like there's a potential for it to take a lot longer, because if you're seeing them every day and checking in with them every day, then, you know, more things come to mind and we're spending more time on different needs. So yes, it does take a lot more time.
Do you use tabs or films? Or both?
What'd you say?
Do you use tabs or films, or both?
We use tabs.
And you don't wait for the tabs to completely dissolve for the patient before they leave?
It's not completely gone within that 10 minutes, but it's close.
Okay. I'm always worried about diversion.
Yeah, that's completely, I totally get what you're saying. Like a big reason that we did daily dosing is because of the risk of diversion. So, I mean, I'm not like, you know, doing like mouth checks for every single person every single time, but we're sitting there for a good 10 minutes.
So do you room patients while they're waiting, or do you just have them wait in the waiting area? Because I know for us, it takes like 10 minutes for the in-clinic dose to get there from the pharmacy.
If lucky.
And then maybe that's just because...
No, we just have them in our med room. So like it's like a normal nurse visit. So they're roomed, and then it's just like we have access to it right there. So then we're sitting with them for while it dissolves.
Got it. So you just do your own opioid counts and controlled substance counts every day in clinic and kind of monitor that?
Yeah, exactly.
Got it.
Is it patient specific, or is it just like a general like tab of like box of Suboxone you keep?
I'm sorry, I couldn't hear you.
Is this patient specific, like the medications they keep? Is it like you know, Bobby Joe has her meds, Phil has his meds, or it's just like one jar, like everybody comes in and gets their dose, you take it out of one jar?
It's from clinic stock.
Yeah.
Yeah, exactly. We just have, like, we don't have like a Pyxis or anything, but we just have like a stock, and then we just have like a log that everybody, you know, everyone comes out of that. Yeah, so it's not actually the reason that our hospital pharmacy like eats the cost is because we're not able to write a prescription and then keep everybody's prescription in our possession.
Right. Yeah.
So it's not even actually a prescription, it's just like a clinic order.
Yep. Yeah, we've kind of debated that, where it's through OTP if we can dose people with bup through the clinic, and it's that same kind of debate that we've had about, you know, does it the pharmacy management case that we have to get tubed up because our system is bigger. Right now, our clinic capacity won't have us count it, versus, but that just takes extra time, and if people hang out in the waiting area, or do you room them, or do you like, how do you manage, because it turns into like a 25-minute visit. People are in the waiting room to finally getting roomed when the med arrives, versus having somebody where they get the prescription, but then we just like store it for them. But then every day you have to count it, and for however long the prescription was. So it's just a different burden in terms of where you place the time. So that's why I was really curious how you guys are operationally doing it up in Bemidji. That's interesting.
Yeah, and we don't, not every single one of our patients has to do daily administered therapy. Like I have one person who lives like 50 miles away and she comes 3 days a week and gets a partial fill at the pharmacy. So she gets, you know, 1 dose in clinic and then goes to the pharmacy and gets like the next 2 days because that's just working better for her than having all of her medication at home because then she tends to give it away to people. But in, you know, our goal, like your question was like, you know, is that financially feasible for us? And I don't really know, like I heard you mention, you know, in the previous hour, like some treatment programs who do like daily dosing kind of don't want to give people up because of that, you know, reimbursement they get. I don't really think ours is that profitable, but we don't want to keep people doing daily administered therapy for a long time. Like we're constantly trying to, you know, work with people to get them to have like take home doses. But some people just really aren't there yet. But we kind of start with like, okay, well, you know, you don't have the bus available to you on Sunday, so we'll let you have a Sunday take home or things like that. And then we kind of like work, people work their way up to getting like a week worth at a time.
How do you guys decide that?
What I tell patients is the things we're looking for is for basically compliance and like showing good signs of recovery, like going to their chemical dependency appointments with a counselor, appropriate drug screens, having a safe place to put the Suboxone at home. So I've given a couple of lock boxes out and that kind of thing.
Got it.
But
Cool.
I have some people who have like gone to, you know, weekly take homes and then they have a couple of drug screens that are inappropriate or they've have some dishonesty or things like that. And so we kind of have to take that away.
Yep, you reel it back in. Yeah, that's where it's kind of, we're trying to figure out how to increase our contingency management using that kind of principle. You know, the better things are, then you can kind of just give them more and more freedoms, but then you have the ability to ratchet back. And that's where we're trying to figure out financially, even with our OTP, how we can have that transition be a better opportunity for people. But because of the federal regulations, it becomes really hard. That's why we've been kind of exploring how could we do that as a clinic to have an intermediary step, kind of what you guys are doing. That's where we're trying to figure out how would that look. So,
well, I'd be perfectly willing to talk to you guys about it at a different time and tell you the things we've struggled with and the things we've had success with. So.
Yeah, it sounds like a road trip maybe in my future, if you'd ever be willing to host somebody.
Yeah,
Sure.
definitely.
Cool. Well, thanks, guys. Don't want to take up your whole afternoon, but I really appreciate you sticking around and having the conversation.
Well, thank you very much.
Thank you, Jay.
Thanks, Joe. Thanks, Allie.
Thank you.